Welcome and thank you for joining us this afternoon for today's Lunch and Learn with the Doctor on autism through the lifespan. My name is Kathy Churn and I am a consumer health librarian at East Brunswick Public Library. Today's program is brought to you by St. Peter's University Hospital and the library's Just for the Health of It initiative to promote community health and wellness. Our speaker today is Dr. Mary Merola, Fellow of the American Academy of Pediatrics and Chief of the Division of Developmental Pediatrics at the Children's Hospital at St. Peter's University Hospital. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. Our speaker will answer questions at the end of the talk. The speaker will not be able to offer medical advice to attendees during this program. And without further ado, I'll turn things over to Dr. Merola.
Hi, everybody. I'm Mary Merola. I'm a neurodevelopmental pediatrician. And just quickly, I completed pediatric residency 3 years. I did a 2-year fellowship, and I've been working in this field since 1987 as an attending. I've been here at St. Peter's since 2015 as chief of the developmental behavioral department. I don't have any disclosures, although I am going to be on the board at My Goal Autism Foundation, but I'm not receiving any pay. It's all volunteer. The objectives of the lecture is so that you can begin to recognize the early signs of autism and what to do. You could be aware of the core symptoms of autism that have been the core symptoms of autism since it was first described by Leo Kanner in 1943 actually. I want you to be aware of some of the treatment options at different age groups, and I'm giving you in summary, some resources to use for diagnosis and intervention. As I said, Leo Kanner was a psychiatrist. 1943, he was the first to describe 11 children that he saw with similar characteristics: low functioning abilities, severe social isolation or withdrawal, poor communication skills, and repetitive behaviors. He felt it was attachment issues, at the time, that's where everything was in psychological terms at that point. And his autistic description referred primarily to the severely affected individuals with those symptoms that met those core groups of symptoms above. It was considered rare, 1 in 12,000, 12,500 children. Hans Asperger described a similar syndrome to autism, but with a different level of impairment. It was later termed Asperger Syndrome after Hans Asperger. And these children had the core symptoms of autism, but they had much higher intellectual potential. Lorna Wing, a psychiatrist, in 1995 described the difficulties that these children experienced as a triad of impairments, and that helped explain the complex pattern of behaviors that they saw. Her model recognized how behavior, thinking, and learning could be influenced by problems in communication, socialization, and those with rigidity or limited flexibility and imagination. This model is what helped us to understand autism spectrum from its inception to the present time. Now, how do we make the diagnosis? We use something called the Diagnostic and Statistical Manual by the American Psychiatric Association. The first manual came out in 1980, and now its edition is the 5th edition with some multiple revisions in between, and that came out in 2015. The most current edition changed the name from what you might have heard as pervasive developmental disorder, that was in the DSM-4, to autistic spectrum disorder in the DSM-5 5th edition. Pervasive developmental disorder didn't allow for all diagnoses to be recognized as autism. It was mild, moderate, pervasive developmental disorder not otherwise specified, which was more atypical, and not otherwise specified, also incorporated Asperger Syndrome in it. The problem with that was that 14 states, because they didn't have the numbers of kids in that atypical category, an Asperger category, they didn't have the numbers, they didn't recognize it as autism spectrum and did not deliver services. So we sat down and said, what do we need to do to get all of these kids recognized as autistic so we can get them the services? So the diagnosis then changed in the DSM-5 to Autism Spectrum Disorder. That's the umbrella. Underneath it is mild, moderate, or severe autism, to the higher functioning autism, to the atypical autism. So what was PDD-NOS, not otherwise specified, is now under the umbrella of autistic spectrum disorder. We use one code for it that identifies it. That's the International Classification of Diagnosis Code in its 10th revision, and that is F84.0. If you don't have F84.0 as a diagnosis, there are certain treatments you do not get. The diagnosis of autism through all of its revision, from the time of Leo Kanner's first description through the present time, has always held true to the core criteria of autism. What are those core symptoms that have never changed? Severe social skills deficits, have to have it. Social communication limitations, have to have it. Restricted interests and actions, you have to have some of those. You have to have many of the social communication issues and some of the restricted interests and actions. The triad of impairment that we see in those three categories results in the behavioral presentation we see as autism. These deficits that they suffer definitely impact their ability to learn and function in society to varying degrees depending on their presentation. Each autistic client is unique in their own presentation of symptoms, and the criteria of no two people with ASD are exactly alike. They're like snowflakes. There's a little difference. They're all snowflakes, but there's a little bit of difference in each one of them, even within the same family. Even identical twins, I've seen that in identical twins as well. There's varying degrees of symptomatology, but they all meet the core symptoms. Sensory and motor deficits may be present as part of the clinical syndrome. They may have poor coordination. All of them have some form of sensory integration disorder, and we'll discuss that a little later. There are families with only one offspring that has autism, but they may have 3 or 4 other children that are healthy, or might have some mild speech delays. But there also are families where they have 3 or 4 children on the autistic spectrum, and each one presents a little differently from their sibling, but they all meet the core criteria. Okay, the DSM-5 diagnosis. We have to meet 3 out of 3 impairments in social communication and interaction. There has to be lack of social emotional reciprocity, lack of nonverbal social communication, and lack of reciprocal relationships. And under each of these categories are multiple symptoms that we describe. But you have to have at least one symptom under each of these 3 characteristics or domains in order to meet impairment in social communication and social interaction. And that is the hallmark of autism. Presence of restricted repetitive patterns of behavior. You only need to meet 2 of the 4 domains: repetitive speech, movement, and use of objects, adherence to routines or rituals, restricted intense interests, unusual sensory interests and reactions. So sensory integration, those stereotypic self-stim behaviors, repetitive actions, ritualistic play, all comes under this heading. The symptoms have to be present in early childhood, but some of them may not manifest until the child's demands are so great it exceeds their capabilities. So I tell parents, the child doesn't have the stereotypic self-stim right now. They may be young or in early intervention, but when we start making more demands, that self-stim comes out because that's their comfort zone. They resort to the self-stim to regroup and find themselves in an environment that's over challenging for them. The symptoms together have to limit and impair everyday function. If they don't, then it's not necessarily autism. Okay, What are the statistics? We all know that the prevalence has increased over time. In the 1940s to 1970s, it was considered pretty rare, occurring in 1 to 3 per 10,000. I remember it wasn't until the 90s that I really started seeing more of the children, but I also changed jobs at that time. So the children that were being referred might have been a little bit different as well. In the 1980s and 90s, the prevalence went up from 1 to 3 per 10,000 to 4 to 8 per 10,000. That was based in industrialized countries on the ICD-10, International Classification of Diseases, and DSM classification at the time. The most recent studies in industrialized countries of North America, Europe, and some areas of Asia estimate the prevalence in the 21st century worldwide to be 2 to 4 per thousand. In the United States, we use Autism and Developmental Disabilities Monitoring Network. And we found the recent prevalence of autism in the United States to be across the country 1 in 68, with pockets of higher incidence in different areas. In New Jersey, there are certain areas that have higher incidence. New Jersey has a higher incidence than many other places, but in a lot of the urban areas, you're going to see a higher incidence because people will migrate to the urban areas so that they can get services for their children. In the more rural areas, it's more difficult. The reason we're seeing this increase, we feel, is due to better information available in the records that are reviewed, more stable populations at the sites, and better identification of specific subgroups like Hispanic children and children without cognitive impairments. So we're seeing that spectrum of children when we when we focus on all levels of cognitive performance. Okay, in New Jersey, the stats are pretty high. The newest stats in New Jersey are based on Center for Disease Control evaluation of health and educational records of 8-year-old children in 2012. Okay, so when they looked at all the records, because a lot of kids are in school, very few are homeschooled, there was 1 in 41 children identified in New Jersey. We're seeing that increase because it's being reported now to the birth registry of New Jersey. Anytime I make the diagnosis, the birth registry has to be filled out, and it has to be filled out as far as whether the child has mild, moderate, severe autism, when the diagnosis was made, when the symptoms started presenting, and what I used to make the diagnosis, what are the accompanying comorbidities of the child as well. Parents, schools, and professionals working with children who are delayed are now more savvy to the core symptoms of autism and referring to pediatricians and subspecialists early. I get a lot of referrals from early intervention and from the schools when they're having difficulty. New Jersey's reviewing the medical and school records and capturing more children with the diagnosis. So we're really looking for that diagnosis and finding it more. Boys are affected more than girls, 5 to 1, and that's across developmental disabilities. Boys are more affected than girls, but especially in autism. So when we look at that 1 in 41, it's actually 1 in 41 boys, but most likely 1 in 189 girls identified. The age of diagnosis can be made as early as 2 years of age. In some kids, it's very clear. In others, there are red flags, and we wait to see it. But most children are not diagnosed with autism spectrum by community providers until they're nearly 4 years of age. I've diagnosed it in younger kids, but I'm a subspecialist, and so this is more my area. There was a question, can you diagnose it in a 5-month-old? No. Lower socioeconomic status and minority children were less likely to receive professional evaluation under 3 years of age, but parents are becoming more savvy. They're connected to the internet, they're looking things up, they're going to their pediatricians, and the children are being referred. So we're seeing more children in that patient population. The IQ among kids identified, in the literature, there's about 30% of the children have an intellectual disability. There are some studies that suggest it's higher, 40 to 70%, but that's based on the population they may be reviewing. So they may have a population of kids more severely involved being referred, and therefore their numbers are higher. When we look at a decade of surveillance in New Jersey from birth to 21 years of age to show the increase, it went from 1 in 150 in 2002. And this chart, 1 in 166 in 2000, 1 in 150 2002, dropped to 1 in 125 in 2004, 1 in 110, 2006, 2008, it was 1 in 88, 2010, it was 1 in 77, then 1 in 68, down to 1 in 41 in 2012. So there has been an increase across the state, but we are really good at identifying these kids and reviewing records to find them for identification and services. Now, what are some of the factors contributing to autism? We know by and large it's genetic. The twin studies have shown us that identical twins who have one sac have a higher prevalence of autism spectrum than fraternal twins with two sacs. There's 90 to 95% occurrence of autism in the identical twins, although their presentation may be a little bit different. There's a 3 to 9% occurrence in fraternal twins, which is the same occurrence if you have one child in the family with autism. There's a 3 and 9% chance of having a second child with autism. Much higher, 40% risk of having a child with speech delay. We can identify genetic mutations in about 10 or 15% of the children with autism. And as technology improves, we expect to identify more. There are about 7 to 20 genes on the genome that produce the symptom presentation of autism. And as I said, there's a 3.9% recurrence rate in families when there's one member. We believe that the multiple genetic and environmental interactions are likely, but evidence to support this is limited, and we still do not know what predisposes a child to develop autism. But we know it's genetic with environmental factors. So what are we doing? We're looking at any potential environmental factor in each individual child. We look at the prenatal environment the child was in. We look for exposures to drugs, alcohol. Was the mother sick and on medications? Things like that we're looking at. Were there hormonal imbalances? There's been some research to show that mothers who develop hypothyroidism in the early part of their pregnancy may have a higher risk of producing children with autism spectrum. You know, because any kind of shift, those first 3 months of life, when the brain cells are being laid down and everything's going to be decided in what they're going to do in the brain and all, in the early part of pregnancy, that first 21 to 42 days, a lot is going on with the baby. And we think something might have happened in that period of time. We look at the perinatal events. Was it a complicated delivery? We're looking at all of that as well. Some of the studies show higher incidence in premature infants, but they're born early. And they have much more chronic problems. If they've been in the neonatal ICU for a very long period of time with a lot of complications, that they could have problems. They have sensory integration issues as well. And we know that all autistic children have sensory integration issues, but not all children with sensory integration have autism. Some of the studies show a higher incidence in children conceived by in vitro fertilization as well. The only thing we have seen across the literature is that the older the parental age at conception, the higher the risk for autism. But when we look at the actual numbers, it only accounts for 0.5% of the cases of autism. Socioeconomic status, this is one condition, like developmental delays across the board happen at a higher risk in lower socioeconomic groups, but there's a higher risk for autism in the higher socioeconomic groups. Okay, we studied many of the factors that could be implicated in the cause of autism in particular patients, but have not found any factors that explain the overall increase over time. We take careful histories in all of the children diagnosed with any developmental delay, and especially autism, might place the child at risk for it. We check the genetics in all of the children diagnosed with autism. I do 3 specific genetic tests, Fragile X, I do just regular chromosomes, and then I do a special chromosome looking for tiny micro deletions and duplications. When I find something, the child goes to the geneticist, and the geneticist then looks at what I found that might be abnormal and decides what further tests need to be done. We're gatherers of information because we want to find out the cause and then try to prevent that cause if we can. We still don't know what predisposes children to develop autism, though. With all the research that we have, there's nothing specific. Vaccines over and over have been tested in our literature and have not been found to be the cause of autism. Okay, what are the early signs? If you look at the brain that's up there in the right-hand corner, that little green spot is the amygdala. In the amygdala, joint attention occurs. This joint attention develops between birth and 2 years. When you have lack of joint attention, that's one of the red flags of autism. In the picture on top, mommy and child are looking at each other. There's attention to each other. That begins around 4 or 5 months of age when the baby's feeding at the breast or being fed by bottle by the mother and mommy's talking to the baby. There's eye contact, there's connectivity. The child is staring at the mother. By 2 months, starts smiling at mommy and developing more joint attention. Not turning to name, big red flag. Not pointing for their wants. And it's not just throwing their hand out and yelling. That's not pointing. Pointing with your finger, looking at mommy, looking at the object, looking at mommy. 3-point gaze that says, hey, mommy, I don't know what that is, but I want it. No pointing to show, which is the little boy in the second picture. All right? He's pointing, but we want to see him look at mommy, look at the fish or whatever he's looking at, look at mommy again and say, hey, look what I found. Fixation on tiny parts of toys rather than playing with the whole toy as well is another red flag. Joint attention is universal and specific to autism. It's the inability to coordinate one's own attention between an object and another person. That pointing for once is proto-imperative pointing. We should see it by 12 months of age. Sharing an interest, proto-declarative pointing. Hey, mommy, there's Mickey at 14 months. We know that when the child develops joint attention, within about a year, they'll start speaking if they're nonverbal. So part of our treatment is to help them develop that joint attention, and we'll talk about that in a minute. When does joint attention develop in a typical child? 2 months, reciprocal smiling. 5 months, they're attached to mommy or the caregiver. Somebody strange walks in the room, they get a little closer to mommy, they look at you, they look at mommy, okay? And they want to know, who is that person? I don't know them. That's attachment beginning. 8 months, gaze monitoring. Walk into a room, especially the doctor's office. You look at the doctor, you look at mommy. If mommy's smiling, I'm okay. If mommy's crying, I'm in big trouble. So that's gaze monitoring. By 10 months of age, following a point, mommy points, says, oh, look, there's Mickey. And the child looks. What is she looking at? Okay. 12 months is that pointing for what you want. 14 months, pointing to show. And 14 months, the child brings an object to mommy, but is not just coming to mommy and shoving the object at mommy. Is bringing the object, looking at mommy and the object and say, what's this? How do I do it? There's communication and connectivity that we're looking for. Theory of the mind. This happens in that purple area of the brain and that little dark maroon area of the brain, the frontal cortex and that tonsil, amygdala again. This you see in kids that are a little older and more communicative, a lack of realization that others have thoughts or emotions independent from one's own emotions. It's a mind blindness. You cannot take the perspective of another. I see it a lot in the older autistic kids that are higher functioning when you're trying to reason with them about something that's going on in their life. They know the answer, you don't. And they just can't take your perspective. They don't get it. That's that mind blindness. Okay, so how does the child 2 to 5 present? They may present nonverbal. Many times, the kids that I see between the ages of 2 and 5, 50% are nonverbal at the time they're seen. 20 to 30% have a history of regression between 1 and 3 years of age. And you know, people were saying, oh, he got his shot and then he stopped talking. He got his shot and he stopped looking at me. Well, it happened at the same time that vaccinations happened, but it happened in Kanner's time. to 20 or 30% of the population as well. So that hasn't changed over time. And that regression still occurs. We look to see why. I send the children to the neurologist, who then looks at the regression and does the MRIs, EEGs, and whatever studies they need to do to make sure it's not a brain degenerative disorder. No functional language. There are children that can recite the alphabet, can read at second and third grade level at the age of 3. They don't always understand what they're reading. They know the alphabet, they know numbers, they know labels, and they can read, but they can't use that language they know to communicate their needs to other people. They may have an inconsistent use of words. They may also have neologisms, which are made-up words. When we look at the language of the children who are speaking with autism, there's a dissociation between the form, which is the syntax and articulation, which is increased, and the function, the pragmatics and the social use of language and the body language or nonverbal language, that's diminished. Self-directed play, parallel or solo play after 3, 4, 5 years of age. Children will parallel play or solo play at 2 years of age with the emergence of some pretend. They'll go and they'll make you a plastic sandwich and give it to you. They'll feed the dolly at 2. By 3, their pretend advances to more of a symbolic play between 3 and 4. They can take a stick and make it a magic wand, all right? And they want to play with other children by 3. By 4, there's role play. I'm Superman, you're Batman. All right, I'm this Ninja Turtle, you're that one. They're not interested in peers or their environment between 2 and 5. They're focused on the small parts of objects like spinning the wheels, spinning themselves. They may have a hard comfort item, walks around with a string or a rock or a car or a stick, and he has to have it in his hand wherever he goes. They may join into play if the peers are doing what they want, many times running and chasing games, but they don't interact. They may sit next to the child who's building with blocks, and they're building with blocks, but don't touch their blocks and don't rearrange what they did. Okay? They may have repetitive actions, toe walking, running in circles, spinning themselves or objects, lunging back and forth. That's in the lower functioning kids, where the front top of their body precedes the bottom part of their body as they run. They may have rigidity, obsessive compulsive repetition, or ritualistic play. They line the toys up. You misalign it, they have a meltdown. They're sorting by color. You mix the colors, they have a meltdown. Restricted interests. Some of the kids may be interested in cars, dinosaurs, Legos, letters and numbers. Letters and numbers are pretty popular. But I think they watch a lot of technology and they're memorizers. So they fixate on letters and numbers. You try to get them to do something else, they bring the letters and numbers back in. Some of the higher functioning kids maybe have a fascination with cars. I had one child who knew the make and model of every car ever made. He knew every dinosaur. So they can have amazing memories for facts, but they can't always use the words that they know to interact with others. They may have repetitive speech, echolalia. Echolalia occurs between 1 and 3 years of age in children who are language delayed as well, because they're learning to imitate language in order to speak. If they have a desire to speak to you, they may imitate. But in autistic kids, the echolalia is very specific. You say, come here, they say, come here. You say, what's your name? They say, what's your name? Say, my name is Joe. They'll say, my name is Joe. So that's immediate echolalia. They may have delayed echolalia, where they can recite the dialogue from TV shows, but that's their speech, the dialogue. And mom will usually say, I'll say, what is he talking about? Because I don't know some of the news shows for little kids. And they'll say, oh, he saw that on Power Rangers. They may have scripting, phrases that they've learned through therapy, whether early intervention or other therapy, how to ask for something. I want. And they'll say, I want this, I want that, but they'll always say it that way to express themselves. That's scripting. Part of that is the treatment for nonverbal kids to get them talking. You get them saying words, cookie, juice, milk, for what they want juice, want milk, want cookies, which was what 2-year-olds say. And then you advance them to I want I want juice. I want go outside. I want this. I want that. So we'll teach them how to script so that they can communicate with less frustration. Some of the higher functioning kids would have a very formal speech pattern. So, doctor, what are you doing today? How do you feel? Very pedantic or formal speech pattern. So that's in 2 to 5-year-olds, what we're looking at. In the school age child, 6 to 12, their play may be inappropriate. They invade other space. They play immaturely for age. Their interests are immature. They may migrate to the younger children or adults, but not same age peers. And they have a strict adherence to rules of a game. It has to be played this way, otherwise they have a meltdown. They cannot sustain conversations. They can be taught, hi, my name is Joey, you want to play? But then they don't know what to do after that. Their conversations may be self-directed, fixed on their preferred topics. All right, so they may or may not have success with the same age peers. So they'll start talking about dinosaurs when the other child wants to talk about Power Rangers, and so the other child will walk away. They cannot read the nonverbal cues and gestures of others and adults, peers and adults. So they don't know if somebody's interested, and they go on and on and on about a topic. They may be off topic in conversation. You start one thing and then they go into something else. They cannot maintain friendships. They're so socially awkward in groups. They don't want to interact with their peers and prefer adults because an adult's going to work with them to redirect the conversation and keep it going. They may have no interactions with others. Their odd behavior, there may be odd behaviors and rituals, the self-stim behaviors like spinning, hand flapping, pacing, jumping, lateral gaze. They take the object and they're looking at it from the side. They're tilting their head to look at the TV. I had one kid who liked to run across picket fences and just look at what he saw when he was staring at it to the right as he ran. They may have odd speech patterns. They may still have that scripted speech with echolalia, and they have monotone speech. They lack that melody of speech, the prosody, to let you know what they're feeling, what emotion they're feeling. So it's more unemotional speech. All right, how do they present in the adolescent? The high functioning and low functioning. The high functioning child may be in regular ed with or without supports. All right, they're literal learners. So pragmatic thinking is not there for them. Abstract reasoning is not there. So they may do well in first, second, and third grade, but when they get to fourth, fifth, and sixth, when they have to abstract more, they may have difficulty. So they were memorizers at first, and now that it's getting more complex, the learning, they're starting to show some learning difficulties. They may have social issues. As we grow from 1 to 3, 3 to 5, 5 to 9, 9 to 12, our social experiences are different. And we need to go with the flow and become flexible. These kids don't have that flexibility and need to be taught the social etiquette as they grow. They may have odd behaviors and rigidity that really interfere with their ability to perform. In the low functioning child, they can still be nonverbal as adolescents and have very limited expressive speech. They may need special ed classes and many supports. They may need help making decisions. So when they become 17, 18 years of age, if they can't make their own decisions, the parent needs to become their guardian. And they may have behavior problems anywhere along the line. What are the behaviors associated with autism at any age? Attention deficit and hyperactivity may present. Sensory regulatory issues may be part of that hyperactivity presentation. Hyperactivity may be a response to not wanting to do something or being defiant. Self-injury, head banging, biting, scratching, skin picking. It's common in all children with developmental delays, but especially autistic children because they have really low coping mechanisms and poor frustration tolerance. Aggression towards other may be found. That's their communication. I don't want to do that. So if I spit at you or hit you or bite you or kick you, you may go away and I can do what I want, which is to self-stim. They may have picas, ingestion of non-food items. All right. We always look for iron deficiency and lead and stuff like that in picas. In fact, I found a 15-year-old whose only change was in behavior. When he was 15, he went from good behavior to bad behavior, which could have been just the adolescent change. But when he came into my office, he licked everything that was in the office. I did a lead level and he had a lead level of 100. Don't know why it was so high and why he wasn't sicker, but he was. Obsessive compulsive behaviors and rigidity. Ritualistic play, that lining up of things, the sorting by color. I play this way. When I go in a room, I shut the door. I had one child whose mother said when he goes into the bathroom, he opens the light 3 times. When he leaves, whether you're in there or not, he shuts the light. And if you change it, he has to do it all over again. That's that ritualistic behavior. Need for sameness. These kids have a terrible time when you change their routine. They go to school, they expect to get up, to eat, get dressed, go to school, on the bus, do what they need to do in school, and come home. You change that routine, and they're having a bad day. They may have tantrums. When COVID happened and they were no longer in school, terrible time. A lot of these kids in August, even if they have summer programs, in August, the lower functioning autistic kids don't have class. So we tell the parents, you got to have activities for them, because when they go from a structured class to home, they have that need for the sameness and they don't have it. You got to give them some structure at home. Otherwise, they're going to have meltdowns till they start school again. Difficulty with routines that change, we talked about. Stereotypic behaviors are behaviors that occur at any age. They usually don't occur in the younger kids, but they can be seen 2 to 5. Sometimes they're not seen till the child goes to pre-K and starts getting challenged more. Associated findings. Okay. Along with the autism, intellectual ability can be low, average, or high. 30% in studies have shown intellectual impairment under 70. Any of these children could have learning disabilities. As I said, they're literal learners. The abstract escapes them. So processing of word problems may be difficult for them in math, but the calculations, high as can be with calculations. Language impairment can be mild, moderate, or severe. The language impairment may give rise to behavior problems when they can't express their needs. So sometimes the early treatment is to teach them how to say stop, all done, I want, and give me, so that they can communicate something and not get frustrated. They may have precocious high functioning autism, which may make the diagnosis more difficult if they're not having a lot of social issues. If they're, going with the flow, they're more flexible. They may look like they're socially interacting more. So you may have to look at videos to see that component of it, and it may not be picked up until later. Genetic findings. Children with Down syndrome, Fragile X, and Rett syndromes are specific syndromes that have been associated with at least a small number of cases of these children may have autism as well. And as I said, it can occur with the microdeletions and duplications in those 7 to 20 chromosomes. Medical issues, neurologic, they can have seizures. Peak age for seizures is 3 years of age, but especially in adolescence, occurs overall in 15 to 20% of children with autism. GI or digestive issues and feeding disorders, whether sensory and or behavioral feeding disorders, can occur. Allergy and immunology disorders can be found in these children as well. So we look at them medically with multiple specialists. Psychiatric conditions, anxiety high on the list, ADHD high on the list for these kids to be comorbid or secondary to their limitations. Depression can occur, especially in the higher functioning kids, if they haven't had success socially. Mood disorders can occur in these children, just as in the general population. And aggression frequently happens when they're frustrated, can't communicate their needs, or when you're trying to get them to change a negative behavior, whether it's a self-stim or a tantrum. It may lead to aggression as well. So how do we intervene? Through the lifespan, any one of these therapies will be needed. ABA, definitely needed early on, especially if the child's nonverbal with severe social issues and low functioning. Applied behavioral analysis, and I've given you a handout, is a behavioral approach to promoting attention, focus, joint attention, body language use, and communication skills. Speech therapy. All of the kids require speech therapy at some point. Occupational therapy depends on the sensory and motor needs that they have, but at least early on they'll need it. Physical therapy, if they have low muscle tone and gross motor needs, they'll need it. Life skills training is something that we do as parents, teaching our kids to get dressed, feed themselves, dress themselves, wash and dry their hands, take a bath, use the toilet. Those are all the life skills. So we do that naturally. Those kids that have a lot more difficulty with that will require life skills training. The ABA therapist would do that early on. They do it later on as well. Social skills training is needed throughout life for these kids. They'll have social issues as they grow, especially in middle school, which is the most social time in anyone's life, and typical kids have issues with it. So atypical kids are also. Vocational training happens when they're older in high school, and we'll talk about that later. They all require individualized educational plans. They may be in different classes with different supports, but they all need an IEP based on the diagnosis, and they need accommodations at school as they grow. Okay, applied behavioral analysis, specific approach to the management of autism at all ages. And it's the only treatment in the literature that's considered the hallmark of care for autism spectrum disorder. It's needed to help them develop joint attention or joint referencing, that connection with mommy and peers, language and communication skills, daily life skills, and just general attention skills as well. And they also reduce negative behaviors. If there's behavior problems, the ABA therapist is coupled with the board certified behavior analyst, and they're evaluating behaviors. Why is the child having a meltdown? We look at what the antecedent cause was, all right, which that's a functional behavioral analysis, the ABCs. What's the antecedent behavior? Okay. What did the child do? The behavior itself. And the C being, what was the treatment for it? What did we intercede with? All right. So if the child hits because he doesn't want to do math, and you say, okay, you don't have to do math, guess what? He's always going to hit because he doesn't want to do math. So we need to know the cause of that and develop a plan of action to get around it, because otherwise they would never progress. Parent training is part of ABA. And the reason for that is consistency. If we're doing something in school and in ABA, you need to be doing it the same way at home. There's less confusion for the child, and the outcome is better. It promotes language and learning much better because there's lack of confusion, there's consistency and structure in all domains, whether it's at home, at school, or play. Okay, speech therapy and social skills. When a child has significant speech deficit, they're going to be at risk for social skill deficits, especially the autistic child who has that social communication problem. Hearing tests are done by pediatric audiologists as part of the workup. I want to know, does the child hear all of the speech sounds they need to hear? Or is that compromising their ability to express themselves? Speech on an individual basis is delivered in the nonverbal child or the child with significant receptive language deficits. Speech groups are used at school and privately to develop the social skills, communication skills they need to help them make and sustain conversations, to have reciprocal language interaction, to learn how to read gestural cues. You need to know if Johnny Jones is interested in what you're saying. If not, maybe we need to say to Johnny, what would you like to talk about? And then you can begin a conversation. To learn how to navigate play, deal with conflicts without having a meltdown, or deal with conflicts without being aggressive. The social skills groups in most places begin around 7 to 9 years of age to help the child develop social etiquette that's needed to engage successfully with peers. At younger ages, the schools and private agencies between 2 and 5 or 6 years of age are doing social skills groups, either geared to the child's occupational therapy needs and sensory needs, or the child's language needs, or both. Occupational therapy and physical. Children with motor and sensory skill deficits need occupational therapy. If they have gross motor delays and low tone, they may need physical therapy. All autistic children have sensory integration deficits and can be sensory avoidant, sensory seeking, or both. A sensory avoidant child is a child super sensitive to noises, who covers their ears. You go into a group, it's too loud. The group is too big, I gotta leave. All right, that's sensory avoidant. Sensory seeking child is the one that doesn't feel the senses so much, has to touch everything, invades people's spaces, need to be close to people, undersensitive to touch. I have some kids who can bounce off a wall and you'd think they really hurt themselves, and they might have, but they don't feel it the same way we do. And they go on and do more things. They want a roughhouse because they need that deep sensory input. They're sensory seeking. They're constantly jumping, climbing, bouncing because they're sensory seeking. Proprioceptive, and that's vestibular senses. You need to be running, jumping, climbing, bouncing, swinging. So we feed that sense to help them regulate their senses and get their little computer that's offline because of the sensory integration issues back online so they can learn. Many autistic kids have fine motor and gross motor coordination issues or low muscle tone, hence the need for OT and PT. And if you look at that picture that I have there, when an occupational therapist is doing sensory motor therapy, they're also addressing the child's social and behavioral needs by helping them deal with their sensory abnormalities and motor abnormalities. So resulting in better performance, more success, less negative behaviors. Feeding disorders can occur. I have some kids with feeding disorders and some that do just fine. The feeding disorder can be behavioral with sensory issues, can be sensory alone. When it's a sensory feeding therapy, a speech feeding therapist can deal with that. If it's behavioral feeding with and without sensory issues, then you need a team approach, a psychologist, speech therapist to make sure the motor skills are there and they're not gagging because they can't move the food and they're not chewing it well, an occupational therapist to deal with the sensory issues that may be impacting feeding. Gastrointestinal disorders, most common, food allergies, can be treated by a gastroenterologist or an allergy immunologist. Elimination disorders, a lot of these sensory kids are hard to toilet train. They'll urinate on the toilet, but when it comes to stool, when you sit on the toilet, the sensation you have in the rectum is intense. It's a lot easier to stand up and stool than it is to sit on the toilet because the sensation is too great for them. So we do positive reinforcement behavioral therapy to get them to sit on the potty. They get rewards when they sit on the potty for a period of time. They get an absolute reward when they have a bowel movement. We keep the bowel soft and ready to go. Sometimes we have to use medications as well to calm them down. Okay, psychiatric problems associated with autism. We discussed some of it. ADHD, high on the list, anxiety and obsessive compulsive rigidity can be present. You need behavioral support with a behavioral therapist, working with the parents on changing behavior, and sometimes medication. Depression can occur in the high functioning kids who don't have success making friends or being teased or bullied. Sometimes you won't know they're being bullied because they don't know how to express it to you. So you need to be aware to check that as well. And the child needs to have a protocol to follow if they're being bullied, because it's not going to get any better unless they have a protocol and someone to stand up for them. Aggression to self and others. Oh, the other thing for bullying that I usually recommend for these kids, if they can handle it, is martial arts. When a child practices martial arts, they are more self-assured in the way they carry themselves and they're less likely to be bullied. So I push martial arts for these kids. We push mindfulness, little picture in the corner, anything that relaxes them. Play outside, exercise, 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 exercise. The more they exercise, run, jump, climb, swing, bounce, the happier they are. The better they eat, the better they sleep, and the less stressed they are. Aggression to self and others can occur in children, especially when they can't communicate their needs, when their preferred vocalizations or actions are challenged by the clinicians and parents. They'll require a behavioral plan with possible medications. Early identification. The brain is plastic, we know it. Early identification and intervention in any developmental delay has a better outcome. The plasticity of the brain to develop and recoup new skills is found throughout life, but most significantly in those first 5 years. Autism spectrum can present with different needs through the lifespan, requires pediatric and developmental follow-up, and all medical, neurological, behavioral intercessions. Rehabilitation is a combination of medical, educational, and behavioral support through the lifespan. Why is it important? Early diagnosis allows the infant and child to begin rehab, education, medical, and behavioral supports, allows the family to become an integral part of the team. If we're doing one thing and the family's doing something else, we're not going to succeed so quickly. Parents have to be taught what we're doing. It can prevent the development of negative behaviors like anger and frustration and aggression when the child becomes frustrated. The parents can be taught the best approach to their child, and with the consistency of care, the outcome is always better. So rehabilitation, okay. Birth to 3. You suspect your child's developmentally delayed, maybe even autistic. You've looked online, you've heard this lecture, you've seen some of these red flags. Frequently, you go to the pediatrician. What do I do? All right, the pediatrician may send them to a subspecialist if they're not sure. And I'll do the evaluation, the neurologist will do the evaluation. All right, you yourself can call early intervention for a home evaluation. They'll come in, there's the telephone number, the website and all. You can call them as a parent and say, I think my child has autism or is delayed. They'll come in and assess. If the child's eligible for services, they'll begin services. If the child's not eligible, you can call them back in 6 months if the child hasn't progressed, right? Or then you can go to the pediatrician if you're really worried, and they'll send them to a developmentalist, and we'll look at what the issues are and what the child's needs might be. All right, ABA board certified and a board certified, an ABA specialist and a board certified behavior analyst will deliver the therapy, and that can be recommended by the pediatrician and the developmental specialist. Speech and feeding therapy or team therapy as needed can be recommended. OT, usually involved in the young child with autism who tends to have more sensory motor issues, can begin. Sometimes the kids age out of OT. If they don't have many sensory issues, their motor coordination improves. Speech will probably continue, and physical therapy will be part of it as well. Any child in early intervention can get PTOT in speech, and they can get some ABA, but we usually refer outside of early intervention because the max you're going to get in early intervention is 4 to 5 hours a week. And usually when I see a kid who's low functioning, I recommend anywhere from 20 to 30 hours of ABA a week. And hopefully they get as many hours as they can. Okay, 3 to 5 years of age. Now we come under the heading of Individuals with Disability Education Act. For anyone 3 to 21 with a developmental delay or a diagnosis. All right, parent involvement in the plan is important. What you develop is an individual family service plan. That F in there is for family. The family's involved with the team. It may begin by bringing the child to school. They get assessed and they go in. Bringing them to the physician with a prescription or a developmentalist, getting a prescription for school. But these children are guaranteed support as long as they meet the eligibility criteria. The child study team will use standardized tests similar to the ones early intervention used between birth and 3. Sometimes if they've been in early intervention will make an exit eval and say, you know what, I still think your child needs services. These are the services they need. You bring that to the school, and the school will look it over, do their own standardized tests to see if the child requires and is eligible for pre-K. They can begin pre-K at 3 years of age. If it's just enrichment they need, they'll get that with speech and OT, an IEP for that. Or they may get a special ed class beginning at 3 years of age. They can get PTOT speech. Feeding therapies sometimes happen in school, sometimes not. Many times that's private. ABA can be given in these programs for children between 3 and 5. Special ed programs for autistic children do exist. Okay. What happens after the child's 5? After 5 to 21 is the next group of children. They don't get an IFSP because that's only for pre-K, but they get an individualized educational plan based again on Individuals with Disability Education Act. 3 to 21, they qualify based on diagnosis, based on eligibility requirements. The child study team assessment is done. It involves a psychological eval for IQ if it can be done in verbal children, with a behavioral assessment and life skills assessment. They do an educational assessment, that's academic testing, a social history to look at the factors that may be impacting on children, and they develop an individualized educational plan and an IEP with either OT, PT, speech. ABA can be part of it as well. That can be added by the school or recommended by a specialist. Special education class for the low functioning kids is frequently after 5, a multi-handicapped class with ABA approach, behavioral support, speech and OT. All right. There are also language learning classes, which are less restrictive if the child's beginning to speak, so they have more language models. Kids in this category will be in class not just with autistic kids, they'll be in class with other children who have language impairment or multiple handicaps. They may involve, it may involve ABA therapy or ABA support, speech and OT frequently. The next category, less restricted, is an inclusion class, which has typical and atypical children, many more typical language models for the child. You need an IEP to be in that class, and you get accommodations. You can get PTOT and speech and behavioral support. General education is another way to address higher functioning autistic kids with an IEP for speech and OT as needed. Social skills and counseling will be needed through elementary, middle, and high school. And so we need to be aware of the needs and deliver that either through the school or privately. All right, now you're in high school. The autistic child who's high functioning with average to high average IQ, good academic skills, minimal behavioral and social needs is in a general education class with the focus on an academic program and college prep. Many of the high functioning autistic kids have an interest in the STEM classes at college: science, technology, engineering, and math. They are the literal sciences. They're very successful. They have good memory skills and great learning skills for that. It's the abstract, like philosophy, history, things like that, that might be more difficult for them. So they tend towards the STEM classes. Some colleges will accommodate for autistic children with a 504 plan under the Rehabilitation Act of 1975. The colleges that have these programs you could find at the website www.thinkcollege.org. Some of the colleges in New Jersey, like Caldwell, Fairleigh Dickinson, Seton Hall, NJIT, and TCNJ, have curriculum for children on the spectrum who are high functioning and can do well at the college level. If the adolescent still has learning problems, social and/or behavioral problems, you want to address the behavior problems with counseling, medication, private behavioral plans. You want to address the social problems through school or privately with social skills groups, sometimes both. And vocational training depends on the adolescent's ability at communication, life skills, independent living, and cognitive ability. That's the same whether you're autistic or Down syndrome. If you have good academic skills, good life skills, not necessarily good academic skills, but good life skills and cognitive abilities that are at least at a 70 to 84 IQ level, and you can communicate, you can be trained to have a job and to live independently. Decisions are made early to mid-high school to focus on college prep academics based on your presentation, cognitive ability, and life skills independence, combined academics and vocational program, or focusing in the lowest functioning kids on vocational programs and life skills that may lead to ongoing need for programs after you turn 21. These programs are all available when you're in high school. You can enter high school at 14 and not leave till 21. All right, the adult with developmental disabilities and autism. After 21, the adult needs to have an open case at developmental disabilities, a Department of Developmental Disabilities. It's based on their intellectual and occupational functional level, their self-help needs, and life skills dependency. They get Medicaid coverage and they get SSI support. Okay, prognosis. The outcomes span the entire range. The level of functioning, academic, adaptive, and language will more accurately predict the outcome. The worst outcomes can be children with cognitive impairment under 70, no meaningful speech by 5, seizures, especially in adolescents, significant behaviors, adult subtype, which is still aloof and low functioning as an adult, and females tend to not do as well as males, but less females are affected. The better prognosis can be associated with early diagnosis, appropriate treatment. You reduce that negativity. Positive experiences in inclusive settings and natural settings. So less behavior problems, better social skills. Lack of significant behavior problems and psychiatric comorbidities, anxiety, depression, mood disorder. And this is mine, interest and ability for sports. Some of the kids, if they are good at sports, the boys, they have an in with their social group. All right, you just need to work on that social etiquette. All right. 10 to 25% will outgrow their diagnosis but remain on. I'm still in conference, bye. Prognosis of autism. Better functional outcome of children and adolescents with autism is strongly related to IQ, and it has to be measured by formal testing, but not IQ alone. Okay, you can have an IQ of 70, but life skills good, communications good, and not too many social issues, and still become functional. All right, still work and still be independent. Children with early language and higher IQ skills tend to do better academically and have employment success. Children with lower IQs, under 70, tend to have a poorer outcome, especially if they have those behavior issues. But they can still make qualitative improvements with behaviorally based therapies. So behavior, that ABA, BCBA is very important through life. Behavior problems, the inability to care for personal hygiene, low ADL skills have a poor outcome overall. Okay, in summary, autism spectrum is a behavioral disorder or syndrome. You have to have the social interaction and communication deficits and some of the restricted play. It has multiple etiologies with strong genetic component and environmental issues that are not clearly understood. It's a lifelong disorder, demonstrating difference in appearance through child and adolescent years as they progress through social and academic demands in their lifetime. It's important to make an early diagnosis. That can't be overemphasized. The need for sustained support through the child's lifetime is important. And the supports are, as I said, medical, academic, social, mental health, and psychiatric as needed. These are some of the contacts. Early intervention, you can call them yourself. Perform care, you can call as well. They tend to need a diagnosis of autism to deliver the ABA services, so you're going to have that. Statewide Parent Advocacy Network is important to know, because if you're not satisfied with the school program your child has, you can call and connect with them and see what the law is. There are some children that are autistic, maybe low functioning, not getting the supports they need. You want to go through SPAN to be sure that your child gets the supports they need based on the Individuals with Disability Education Act. And these are some of the resources for New Jersey that I've given you. My Goal Autism Foundation, when I make the diagnosis, I refer the children there. One thing Dr. Kumaplay and her husband do, who run the program, is they do fantastic education for parents. Newly diagnosed, they have social workers that help you navigate the Perform Care and insurance network in order to get the services you need. So they do some great education as well as fundraising, and they give money to parents in need to help fray the cost of private programs that they may want for their children. This is some other resources that I've gathered through the years. And just in case you needed to know what the ribbon stands for, the puzzle reflects the mystery and complexity of autism. The colors and shapes represent the diversity of people and families with it. And the brightness of the ribbon signals hope through research and increasing awareness. Any questions?
Okay, so Dr. Merola, I just wanted to check with you if you have time to answer questions, because it's 1:09.
I think I could do maybe 10 minutes.
Okay, sure. Okay, so if anyone has any questions, please type them into the chat box.
Somebody did mention incontinence. Children with autism can have incontinence of urine and stool, depending. I had one kid who was afraid of the bathroom for some reason, and now he holds his urine and stool, and he has soiling and incontinence, but he has the core symptoms of autism. Incontinence alone is not a symptom.
So thank you, everyone. So that's it for questions. I'll send out the link to the recording for this presentation once it's uploaded as well as Dr. Merola's handout and a copy of the presentation. So thank you, Dr. Merola, for
You're
taking
welcome.
the time to present on this topic. And the next talk in our series with St. Peter's University Hospital is called Asthma, Finding the Ease in Your Wheeze on Friday, May 7th at 12 p.m. noon. So for more information about that program and to register, please go to ebpl.org/calendar. And thank you everyone for joining us for today's talk, and take care and stay safe.
Thank
Thank
you.
you.
Thank you, Dr. Merola.
Bye-bye.
Kathy.
Bye. Thank you. Take care.